Welcome to this deep dive designed to help you prep for the FRCS plastic surgery exam.
Oh, this is a good one.
We're going to be focusing on the management of morbid obesity
Yeah.
and the essential elements of body contouring after massive weight loss.
A big topic.
This is, as you know, a high-yield topic,
Absolutely.
directly relevant to the FRCS syllabus.
Right. First, let's quickly go over the classifications of obesity using BMI,
Okay.
which you need to know for the exam.
Right.
Morbid obesity starts at a BMI of 40 kilojuran 2, and super obesity starts at a BMI over 50.
Okay.
You should also be familiar with the NIH classification system,
Got it.
which uses the same BMI ranges but categorizes them as class 1, 2, and 3rd obesity.
Okay, so why are these classifications important for plastic surgeons?
Well, it's not just about the numbers.
Right.
It's about understanding the implications.
Okay.
Morbidly obese individuals often exceed their ideal body weight by 100 pounds or more.
Wow.
While super obese individuals can exceed it by a staggering 225%.
That's a lot.
This significantly impacts surgical planning and the potential for complications.
Okay, so let's talk about those complications.
Morbid obesity is associated with numerous comorbidities that increase surgical risk, including osteoarthritis, sleep apnea, reflux, lipid abnormalities, hypertension, and diabetes.
Yeah.
You also need to be aware of the cardiac implications,
Okay.
like congestive heart failure, asthma, and coronary artery disease.
It sounds like a thorough preoperative assessment is critical in this patient population.
Absolutely. You need to carefully evaluate and manage these comorbidities to minimize surgical risk.
Right.
Now, let's consider what happens after weight loss.
Okay.
Massive weight loss often results in significant skin redundancy, leading to further complications.
What kind of complications are we talking about?
Think infections, rashes, pain, and functional impairments.
Oh, wow.
It can affect everything from walking to urination and even sexual activity.
I can see how that would significantly impact the patient's quality of life.
It does.
Yeah.
And that's where body contouring comes in. Body contouring isn't just about aesthetics.
Right.
It's about addressing these physical and psychological challenges.
So it's a crucial part of holistic patient care after massive weight loss.
Exactly.
Okay. So before we delve into body contouring, let's briefly review the surgical options for weight loss itself, starting with bariatric surgery.
Great.
Bariatric procedures are usually performed laparoscopically due to reduced morbidity.
Yes.
They result in significant weight loss and improvement or resolution of comorbidities.
Right.
Can you break down the different types of bariatric procedures?
We can broadly categorize them into restrictive and combination procedures.
Okay.
Restrictive procedures like the laparoscopic adjustable gastric band aim to reduce food intake by manipulating the stomach.
Got it.
The lap band is effective,
Yeah.
achieving about a 50% reduction in excess weight,
Okay.
but can have complications like band erosion.
What about the gastric sleeve?
The gastric sleeve is another restrictive procedure gaining popularity. It involves removing a large portion of the stomach,
Okay.
leaving a sleeve-shaped pouch.
Got it.
This procedure can lead to a mean excess weight loss of 50% at 6 years
Okay.
and has a high rate of type 2 diabetes remission, around 70%.
That's impressive. What about combination procedures?
Combination procedures like the Roux-en-Y gastric bypass, RYGB,
Okay.
involve both restriction and malabsorption
Got it.
for enhanced weight loss.
Okay.
The RYGB is considered the gold standard bariatric procedure,
Okay.
achieving over 50% excess weight loss and boasting a 93% resolution rate for type 2 diabetes.
That's a powerful tool in managing obesity and its related health problems.
Yeah.
Now that we've covered bariatric surgery,
Right.
let's dive into the fundamentals of body contouring.
It's important to understand that body contouring after massive weight loss is not a one-size-fits-all approach.
Okay.
Each patient presents with unique challenges in terms of tissue redundancy.
I see.
Liposuction plays a limited role
Okay.
and is often used as an adjunct to surgical resection.
So what are the primary goals of body contouring surgery in this patient population?
The goals are threefold: functional improvement, aesthetic enhancement, and psychological well-being.
That makes sense. Now let's talk about the surgical strategy. Where do we usually begin?
The general sequence of body contouring procedures often starts with the trunk, abdomen, buttocks, and lower thighs.
Okay.
This is followed by the upper thorax and breasts, then the arms, and finally the medial thighs and face.
That's helpful to keep in mind for surgical planning.
One more critical point before we move on. Meticulous 5V fluid management during and after large volume surgeries is crucial.
That makes sense, given the potential for fluid shifts and complications in these patients.
Exactly. Now let's discuss a vital aspect of body contouring timing.
Okay.
Why do you think delaying body contouring until after weight stabilization is crucial?
I would imagine it's to ensure metabolic and nutritional stability.
You are absolutely right. Which are essential for wound healing.
Right.
Delaying surgery until weight stabilization also minimizes complications, improves aesthetic outcomes, and allows for a more predictable surgical plan.
So ideally, we wait about 6 months.
Ideally, we wait about 6 months after weight stabilization,
Okay.
which usually means 12-18 months post-bariatric surgery.
So what's the ideal BMI range for extensive body contouring?
Patients typically settle into a BMI range of 30 to 35 kg/2 after bariatric surgery.
Got it.
We can consider initial procedures like peniculectomy or breast reduction for highly motivated patients within this BMI range to aid further weight loss and improve comfort.
Okay.
However, the ideal BMI range for extensive body contouring is 25 to 30 kg/2.
That's helpful to know. Why is staging procedures important in this context?
Staging,
Yeah.
which means performing multiple procedures in a planned sequence,
Right.
has several advantages.
Okay.
It decreases complications by reducing anesthesia and blood loss, minimizing tension on wounds, and allowing for revisions if needed.
So how long do we wait between stages?
We typically wait 3-6 months between stages to allow for adequate healing.
Before we move on to specific regions, let's quickly review the essential elements of preoperative evaluation. What are the key considerations for these patients?
We need to record both the greatest and presenting BMI
Okay.
to understand their weight loss journey.
Got it.
Assess the stability of medical comorbidities, including a cardiac evaluation and a hematology consult for patients with a history of DVT. A psychiatric history is also crucial, as many bariatric patients have psychiatric diagnoses
Okay.
that can impact their surgical journey.
Right.
And of course, smoking is a relative contraindication to elective surgery.
What about nutritional deficiencies? They're common in this population, right?
Absolutely.
Yeah.
You need to assess and address common deficiencies like iron, B12, calcium, zinc, fat-soluble vitamins, and protein levels.
Okay.
Preoperative supplementation may be necessary to optimize their nutritional status before surgery.
What lab tests do we need preoperatively?
The essential labs include CBC, electrolytes, BUN, creatinine, urinalysis, LFTs, glucose, calcium, ferritin, total protein, and albumin.
Got it.
The physical exam should focus on regional fat deposition and skin laxity using the pinch test.
Okay.
And remember to assess patient motivation and support systems, as these factors contribute to successful outcomes.
Okay. Let's move on to minimizing complications.
Okay.
What are the key intraoperative strategies?
Preventing hypothermia is paramount.
Okay.
These patients have a large surface area exposed during surgery, making them prone to heat loss.
Yeah.
The University of Pittsburgh has a comprehensive hypothermia protocol worth reviewing.
Can you briefly describe that protocol?
It involves pre-warming the patient with a forced air warmer, maintaining a comfortable operating room temperature, using active warming devices during surgery, and ensuring all solutions and IV fluids are warmed.
What about DVT prophylaxis?
DVT prophylaxis is crucial, given the high risk in this patient population. We use a combination of mechanical and pharmacological methods, including sequential compression devices and low molecular weight heparin administered 6 hours after surgery and continued for 7 days. We also administer antibiotics 30 to 60 minutes before the incision and repeat doses throughout the case as needed.
Let's dive into specific regions, starting with the trunk and abdomen, which often present the most significant deformity.
You'll often see an inverted cone appearance due to tissue descent along the lateral axillary lines.
Got it.
Traditional abdominoplasty techniques are usually insufficient because they don't address the lateral tissue laxity.
Okay.
The fleur-de-lis abdominoplasty is an option for specific cases, but the gold standard for addressing this circumferential tissueposis is the circumferential belt lipectomy, also known as the lower body lift.
What are the key technical points of a circumferential belt lipectomy?
It allows for resection of the entire lower section of that inverted cone, effectively lifting the buttocks and lateral thighs simultaneously.
Okay.
It begins with the patient in a supine position, making the inferior incision first. We then extend this incision laterally to just below the anterior superior iliac spines,
Okay.
Liposuction is often performed on the lateral thighs
Right.
to release zones of adherence,
Okay.
facilitating thigh elevation.
What about the umbilicus?
An umbilicoplasty is always needed
Okay.
to reposition the umbilicus flush with the newly contoured abdominal skin.
Got it.
The patient is then placed in the right and left lateral decubitus positions
Okay.
to perform the posterior resection.
How deep do you go with posterior resection?
It's taken down to the superficial fascia,
Okay.
preserving a thin layer of fat on the deep fascia.
Got it.
Ideally, the final scars should lie below the pelvic rim and be hidden beneath most undergarments.
Okay.
Drain placement is crucial.
Right.
Wide drains are placed both anteriorly and posteriorly.
What about the back?
Yes.
How does massive weight loss affect this area?
Patients often develop upper and lower back rolls.
Okay.
The upper back rolls are usually singular and can be an extension of the lateral breast tissue. Lower back rolls can be multiple and horizontally or upwardly oriented.
Okay.
The circumferential lift can address the lower back rolls effectively.
Got it.
However, the upper back rolls typically require a separate staged procedure, usually direct excision.
Okay.
We must avoid undermining the upper back rolls during the lower body lift due to the high risk of seroma formation.
Scar placement is essential, especially in women.
Yeah.
Where should we place these scars?
The scars should be aligned along the bra line for optimal concealment.
Moving on to the waist and lateral thighs.
Yeah.
What are the common deformities?
The main issue here is a loss of definition in the waist and hips, primarily due to typtosis of the abdomen, lateral thighs, and buttocks.
Okay.
You'll see the excess tissue spiral down the thigh.
So the circumferential lift is the preferred approach here as well.
Yes, it effectively narrows the waist, creates a smooth curve from the rib cage to the hips, and elevates the lateral thighs.
Are there any techniques used to maintain the thigh elevation?
Yes, we suture the superficial fascial system, or SFS, to the deep fascia
Okay.
with permanent sutures on both skin flaps.
Okay.
This creates a new zone of adherence at the level of the final scar, preventing the thighs from drooping again.
Let's move on to the medial thighs.
All right.
What are the typical deformities we see after massive weight loss?
Most patients present with more horizontal than vertical skin excess in the medial thighs.
Okay.
So a vertical medial thigh lift is often more effective than a horizontal lift,
Got it.
although a combination of both may be required in some cases.
Are there any precautions to take when performing a medial thigh lift?
Yes, avoiding tension on the horizontal scar is crucial to minimize the risk of labial spreading. To achieve a harmonious result, abdominal contouring should be addressed before or concurrently with the thigh lift.
Got it.
The medial thigh lift is typically a staged procedure performed after the lateral thighs have been addressed.
Okay.
Liposuction can also be used as an adjunct to address any residual contour irregularities in the medial, anterior, and posterior thighs.
What are the contraindications for a medial thigh lift?
Pre-existing lymphedema, lower extremity DVT, and varicose veins are contraindications.
Okay.
Treat any varicose veins before surgery.
What are the key surgical goals for medial thigh contouring?
The goals are to create a flat contour and minimize labial spreading.
Okay.
We make an incision along the perineal crease on the inner thigh, extending it superiorly based on the excess skin determined by a pinch test.
Are there any essential anatomical considerations?
Preserving the superficial saphenous vein is crucial.
Got it.
We also avoid dissecting anteriorly into the femoral triangle to minimize lymphatic injury. Any resulting dog ears can be addressed along the posterior inferior buttock crease or the anterior inguinal crease.
Now, let's discuss the buttocks.
Right.
What are the typical deformities we see after massive weight loss?
The back and buttocks tend to blend together, creating the illusion of a long vertical buttock height.
Okay.
The central buttock crease descends, leaving minimal soft tissue coverage over the coccyx,
Got it.
and the lateral inferior buttock crease loses its upward curve,
Okay.
becoming more horizontal.
How do we approach buttock contouring?
The circumferential lift plays a significant role in defining the buttocks.
Okay.
It creates a line of demarcation between the back and buttocks, elevates the buttocks, and helps cover the coccyx if there's a deficiency.
What about augmenting the buttocks?
Autologous gluteal augmentation can be considered to enhance buttock contour, especially if the patient desires more central projection.
Got it.
We can achieve this using fat grafting or dermal fat flaps.
Now let's move on to the breasts. What are the key challenges in breast contouring after massive weight loss?
Breast surgery in this patient population is complex
Okay.
because breast tissue volume and characteristics vary widely.
Right.
You'll see a loss of shape, elasticity, texture, support, and volume.
How do we assess the degree of breast deformity?
The Pittsburgh Rating Scale is a valuable tool.
Yeah.
It differs from traditional SPOSIS classifications
Mm-hmm.
and considers apoptosis severity, volume loss, and skin laxity.
Can you give us an overview of the surgical approaches based on the Pittsburgh Rating Scale?
For patients with minimal breast volume and no apoptosis, implant augmentation might be enough.
Okay.
If there is apoptosis but the skin envelope is stable,
Yeah.
we can perform a mastopexy with or without augmentation.
Got it.
For moderate or large breast volume with apoptosis.
Yeah.
A mastopexy or breast reduction is usually indicated.
Are there any specific techniques for this patient population?
Yes, dermal suspension techniques can help elevate the central mound of the breast.
Okay.
Autoaugmentation, which involves using tissue from the lateral and inferior breast folds,
Okay.
can add volume without implants.
It sounds like breast contouring in this population requires a lot of nuance.
It does. No single technique works for every patient. A combination of approaches is often necessary to achieve the best results. And remember that recurrent ptosis is common.
Okay.
So setting realistic expectations with patients is crucial.
Now let's discuss the upper arms.
Okay.
What kind of deformities do we typically see in this region?
Patients often present with severe skin redundancy,
Yeah.
extending from the elbow across the axilla and onto the chest wall.
Wow.
The excess skin is contiguous with the posterior axillary fold on the lateral chest.
Who are the ideal candidates for brachioplasty?
Those with deflated upper arms and a small amount of residual fat.
Okay.
Concomitant procedures are safe
Yeah.
and commonly performed during brachioplasty in this patient population.
Can you walk us through the key surgical points of a brachioplasty for massive weight loss?
The incision is placed posterior to the bicipital groove
Okay.
for optimal scar concealment.
Right.
We use a sinusoidal incision pattern
Got it.
to reduce the risk of linear scar contracture.
Okay.
The incision extends into the axilla with a gentle curve to reduce axillary ptosis and restore a more natural dome shape. We no longer use Z-plasties in the axilla.
How deep do you go with the tissue resection?
We resect the entire subcutaneous tissue down to the muscular aponeurosis,
Got it.
carefully identifying and protecting the ulnar nerve and the medial antebrachial cutaneous nerve. A drain is placed,
Okay.
and the wound is closed in multiple layers with a compressive dressing applied.
What are the postoperative instructions for brachioplasty patients?
We advise patients to avoid raising their arms for the first week after surgery. Gentle range of motion exercises can be started after 2 weeks.
Now let's shift our focus to the face and neck. How does massive weight loss affect this area?
Interestingly, the skin redundancy in the face and neck often exceeds the degree of SMAS laxity, leading to premature aging, which can be distressing for younger patients.
So how do we approach facial rejuvenation in these patients?
We perform a modified SMAS radiodectomy.
Okay.
More skin undermining is required to achieve a smooth contour, but less SMAS elevation is needed because laxity at this level isn't the primary issue.
What about the platysma muscle?
A platysmoplasty is performed if there is significant platysmal banding. Liposuction or direct lipectomy can address any residual fat deposits in the jowls and submental area.
And what about incision placement?
The incision can be extended into the temporal hairline
Okay.
if a posterior and superior vector of elevation is desired.
Okay.
The posterior incision is typically placed around the earlobe and onto the conchal bowl, allowing for a primarily superior vector of elevation on the neck.
Okay.
This often avoids the need for an incision across the occipital hairline.
Got it.
However, if the patient has severe neck laxity,
Yeah.
a traditional postauricular incision with an occipital hairline extension may be necessary.
That covers a lot of ground.
It does.
Let's move on to potential complications. Starting with hematomas.
Okay.
How common are hematomas after body contouring?
Hematoma formation is relatively uncommon, occurring in about 1% to 5% of cases.
Okay.
They usually present in the immediate postoperative period and require prompt surgical drainage and exploration.
What about seromas?
Seromas are more common, with an incidence ranging from 13% to 37%.
Wow.
They are more frequently seen in patients with a BMI over 35 kg too, particularly in the lower back after a belt lipectomy.
How do we manage seromas?
Drains are maintained until the output is less than 30 milliliters over a 24-hour period.
Okay.
Early aspiration before a capsule forms around the seroma is key
Okay.
and can usually be done in the office. Larger seromas may require drainage with a percutaneous closed suction drain. In some cases, we might inject the cavity with doxycycline to help sclerose the walls and prevent recurrence.
Let's discuss another potential complication.
Lymphocyles.
Where do these typically occur?
Lymphocyles are most commonly seen in the inguinal region after aggressive resection into the femoral triangle.
How do we manage them?
We typically start with serial aspirations.
Okay.
If unsuccessful, a percutaneous drain can be placed and doxycycline injection can also be considered.
Okay.
If non-operative measures fail, surgical exploration and ligation of leaking lymphatic channels may be necessary.
Now let's talk about one of the most serious complications, DVT and PE.
These are significant concerns, particularly in patients with morbid obesity.
Right.
The risk of DVT is at least 1% and increases with BMI. Truncal lipectomies carry a higher risk because the increased intra-abdominal pressure can impede venous return from the lower extremities.
What measures do we take to prevent DVT and PE?
We use a multifaceted approach. Low molecular weight heparin is typically administered 6 hours after surgery and continued for 7 days. We also use sequential compression devices, starting preoperatively and continuing postoperatively until the patient is fully ambulatory. Early ambulation with assistance on the day of surgery and incentive spirometry are also encouraged.
Let's move on to wound complications, which are unfortunately fairly common in this patient population.
Yes, wound dehiscence occurs in about 22% to 30% of cases, usually within the first few days after surgery due to excess tension on the wound edges. Skin necrosis occurs in 6% to 10% of cases, and wound infections or cellulitis occur in 1% to 7% of cases.
What factors increase the risk of wound complications?
Tobacco use is a major risk factor, so we advise patients to stop smoking at least 1 month before surgery.
Okay.
Diabetes, active systemic steroid use, and a BMI over 40 kilograms do also increase the risk.
That concludes part 1 of our deep dive into morbid obesity and body contouring. We've covered a lot of ground, from obesity classification to surgical techniques and potential complications.
In part 2, we'll delve deeper into specific regional considerations and discuss best practices for minimizing complications and achieving optimal outcomes in this challenging patient population.
Let's continue our deep dive focusing on crucial preoperative considerations for body contouring after massive weight loss.
A meticulous evaluation is absolutely critical for both surgical planning and minimizing those complications.
What are the key things that we need to assess in these patients?
Well, first, record both the patient's greatest and presenting BMI.
Why is that important?
It gives you a really clear picture of their weight loss journey and helps you kind of assess their current metabolic state. And then you want to thoroughly evaluate the stability of their medical comorbidities. We touched on this earlier, but it's worth emphasizing.
What specific evaluations are necessary?
Well, a cardiac evaluation is paramount. A stress test may be warranted, especially for patients with pre-existing cardiac conditions or multiple risk factors. For patients with a history of DVT, a hematology consult is advisable.
What about psychological evaluation?
Oh, this is often overlooked, but it's crucial. Remember, a significant percentage of bariatric patients have a history of psychiatric diagnoses, which can really impact their surgical journey. Addressing any underlying psychological issues preoperatively is vital for patient satisfaction and adherence to postoperative care.
And of course, we can't forget about smoking.
Absolutely. Smoking is a relative contraindication to elective surgery, especially body contouring, due to its negative impact on wound healing.
Of course.
Patients should be strongly encouraged to quit smoking at least 1 month before surgery.
Now let's talk about nutritional deficiencies, which are common in this population.
Iron deficiency anemia, vitamin B12 deficiency, and calcium deficiency are very frequent. We also need to assess their zinc levels, fat-soluble vitamin status, A, D, E, and K, and protein intake. Adequate protein intake is absolutely essential for wound healing and overall recovery.
So preoperative supplementation is often necessary.
Precisely. We need to make sure that they're nutritionally optimized before surgery.
What lab tests do we typically order preoperatively?
Well, a comprehensive panel should include a complete blood count, electrolytes, blood urea nitrogen, creatinine, urinalysis, liver function tests, glucose, calcium, ferritin, total protein, and albumin.
Okay, and then the physical exam should focus on?
The physical exam should focus on assessing regional fat deposition and skin laxity.
Okay.
We use the pinch test to estimate the extent of tissue resection needed.
What about patient motivation and support systems?
Those are such important factors.
Right.
Patients who are highly motivated and have strong support systems tend to have better outcomes and fewer complications.
Now let's move on to intraoperative strategies for minimizing complications.
Yeah.
We know this is a high-risk patient population,
Oh, absolutely.
so every precaution counts.
Preventing hypothermia is crucial.
Okay.
These patients have a large surface area exposed during surgery,
Yeah.
making them very prone to heat loss.
Okay.
The University of Pittsburgh has a really comprehensive hypothermia protocol worth reviewing.
Can you briefly describe that protocol?
It involves pre-warming the patient with a forced air warmer, maintaining a comfortable operating room temperature,
Okay.
using active warming devices during surgery,
Right.
and ensuring that all solutions and IV fluids are warmed.
Okay. What about DVT prophylaxis?
DVT prophylaxis is critical.
Yeah.
We use both mechanical and pharmacological methods.
Right.
Sequential compression devices are applied preoperatively and continued postoperatively.
Yeah.
Low molecular weight heparin is typically administered the evening of surgery and continued for 7 days.
Got it.
This timing is really important
Okay.
to minimize both bleeding and clotting complications. Antibiotic prophylaxis is also standard,
Yeah.
with antibiotics administered 30 to 60 minutes before the incision and repeat doses throughout the case as needed.
Okay, now let's revisit the specific regions
Okay.
and discuss the surgical techniques in more detail, starting with the trunk and abdomen.
Remember, traditional abdominoplasty techniques are often insufficient
Right.
because they don't really adequately address the lateral tissue laxity.
Right.
The fleur-de-lis abdominoplasty, involving a vertical incision from the xiphoid process to the pubic symphysis, combined with the traditional horizontal abdominoplasty incision,
Okay.
is an option for patients without significant back or lateral cytosis.
But the circumferential belt lipectomy or lower body lift is the gold standard for most massive weight loss patients.
Yes, we start with meticulous markings for symmetry and optimal scar placement. Liposuction is often performed first to release zones of adherence
Okay.
and facilitate tissue mobilization.
Got it.
The umbilicus is detached and repositioned. And the abdominal wall is tightened with fascial plication if necessary.
Okay.
We then perform the posterior resection, taking care to preserve a layer of fat on the deep fascia to reduce seroma formation.
Drain placement is crucial.
Yes.
Where do we typically place the drains?
We use multiple drains,
Okay.
both anteriorly and posteriorly.
Let's move on to the back.
Right.
How do we approach upper back rolls?
Direct excision is usually the preferred approach
Okay.
for upper back rolls. The incision is placed transversely,
Okay.
and we carefully undermine the skin and subcutaneous tissue.
Got it.
Meticulous hemostasis and drain placement are essential.
What about the waist and lateral thighs?
The circumferential lift is, again, very effective in this region. It allows us to create a more defined waistline and lift the sagging lateral thighs.
Okay.
We pay very close attention to the superficial fascial system
Yeah.
and suture it to the deep fascia to maintain the lift and prevent recurrence of ebiptosis.
What are the key considerations when addressing the medial thighs?
When addressing the medial thighs,
Yeah.
we aim for a vertical lift whenever possible to minimize tension on the horizontal scar
Okay.
and reduce that risk of labial spreading.
Right.
We also make sure to avoid the femoral triangle during dissection to protect the lymphatic vessels.
Okay.
Buttock contouring often involves a combination of techniques,
Okay.
including the circumferential lift,
Yeah.
direct excision, and potentially autologous augmentation.
Okay.
The goal is to create a more youthful, lifted buttock contour with improved definition and projection.
What about breast contouring?
Breast contouring after massive weight loss requires a careful assessment of the patient's anatomy and goals. We use a variety of techniques, including augmentation, mastopexy, reduction mammoplasty,
Okay.
and a combination of these approaches.
Got it.
Dermal suspension and auto-augmentation are also valuable tools in our arsenal.
Moving on to the upper arms, what are the key points to remember during brachioplasty?
We prioritize scar placement
Yeah.
and nerve protection during brachioplasty.
Right.
The incision is placed posteriorly to minimize visibility.
Yeah.
And we meticulously identify and protect the ulnar nerve and medial antebrachial cutaneous nerve.
Finally, let's discuss facial rejuvenation.
Right.
What's a typical approach?
Facial rejuvenation often involves a modified SMAS right adectomy
Huh.
with less SMAS elevation than in a traditional facelift.
Mm-hmm.
Liposuction or direct lipectomy can be used to address residual fat deposits.
Okay.
And platysmoplasty may be necessary to correct platysmal banding.
Right.
Incision placement is tailored to the individual patient.
Yeah.
But we often aim for a primarily superior vector of elevation on the neck to minimize visible scarring.
That covers a lot of ground.
It does.
It's clear that body contouring after massive weight loss is a complex and nuanced field.
It requires a deep understanding of anatomy,
Yeah.
surgical techniques, and potential complications.
Right.
Thorough preoperative evaluation, patient education, and individualized surgical planning are crucial.
Okay.
In the final part of our discussion, we'll review some key takeaways
Okay.
and highlight some pearls of wisdom to help you navigate this challenging but rewarding area of plastic surgery.
Okay, let's discuss this crucial aspect of timing in body contouring after massive weight loss.
Yeah, timing is everything in this field.
Right.
Performing surgery too early can lead to suboptimal results and increase the risk of complications.
So what is the general recommendation regarding timing?
You want to wait until the patient's weight has stabilized for at least 6 months,
Okay.
which usually translates to about 12 to 18 months after bariatric surgery.
Got it.
This allows the body to achieve metabolic and nutritional homeostasis,
Okay.
which is, as we've talked about, crucial for wound healing.
Why is that period of rapid weight loss after bariatric surgery detrimental to wound healing?
Well, during rapid weight loss, the body's metabolic and nutritional reserves are depleted,
Right.
compromising wound healing and increasing the risk of complications. Additionally, the skin's elasticity and ability to retract are still in flux during this period, leading to unpredictable aesthetic outcomes.
So waiting for weight stabilization not only reduces complications, but also leads to better aesthetic results.
Precisely.
Okay.
As patients approach their ideal body weight, the risk of complications decreases significantly, and aesthetic outcomes are generally better.
What BMI range do most patients settle into after bariatric surgery?
Most patients typically settle into a BMI range of 30 to 35 kg 2 after bariatric surgery.
Okay.
For highly motivated patients in this BMI range, we might consider an initial paniculectomy or breast reduction
Yeah.
to improve their comfort and mobility, potentially aiding further weight loss and paving the way for better aesthetic outcomes with subsequent body contouring procedures.
But what is the ideal BMI range for extensive body contouring?
The ideal BMI range for extensive body contouring is typically 25 to 30 kg 2.
Okay.
At this stage, we can achieve the most dramatic and lasting results with the lowest risk of complications.
Now let's talk about the concept of staging procedures.
Staging refers to performing multiple procedures in a planned sequence rather than all at once.
Okay.
It's a strategy we use to minimize risks, optimize outcomes, and improve patient safety.
What are the key advantages of staging procedures?
It reduces anesthesia time and blood loss,
Okay.
which are significant considerations in these often lengthy and complex procedures.
Right.
It also minimizes opposing tension forces on the wounds, improving healing and reducing the risk of dehiscence.
Okay.
Furthermore, staging allows us to assess the results of each procedure before moving on to the next, providing the opportunity to make adjustments or revisions as needed.
So how much time do we typically wait between stages?
The typical interval between stages is 3 to 6 months,
Okay.
allowing adequate time for healing and recovery before proceeding to the next procedure.
Before we conclude, let's recap the key takeaways and pearls of wisdom for navigating the complexities of body contouring after massive weight loss.
First and foremost, remember that this is a high-risk patient population with unique anatomical considerations and potential complications.
Right.
Thorough preoperative evaluation, including assessment of medical comorbidities, nutritional status, and psychological well-being, is paramount.
What about the timing of surgery?
Timing is crucial.
Right.
Always wait until the patient's weight has stabilized before proceeding with body contouring.
And the surgical approach.
Staging procedures is often the safest and most effective approach.
What about communication with the patient?
Communication is key.
Yeah.
Discuss the patient's expectations and priorities and set realistic goals.
And finally, the surgical techniques themselves.
Mastering the techniques we've discussed, from the circumferential lift to specific regional procedures, is essential for achieving optimal outcomes.
Right.
Always prioritize patient safety, meticulous surgical technique, and thorough post-operative care.
That wraps up our deep dive into morbid obesity and body contouring for the FRCS exam.
It does.
We hope you found this review helpful,
Absolutely.
and we wish you the best of luck on your exam.